some technical issues earlier, so I just wanted to double check and make sure everything was working. So very excited. Welcome to our Preparing for a Lifetime quarterly meeting for our partners. We're very excited today. We have a lot of things going on. It is Prematurity Awareness Month. Also Prematurity Awareness Day on the 17th. So wear your purple, show your support. And also our focus for today is going to be on prematurity. So I'm glad that all of you have joined, kind of where we are, what's going on. March of Dimes is going to present the report card. Now that is embargoed data, so please do not share, and we won't be able to send out the slides in relation to that data until the embargo is lifted and the data is released. But so you'll be first to see it in Oklahoma. We do have a lot of work ahead of us. We made some headway, and then we've had some downturn both in the nation and in Oklahoma in trying to beat prematurity and improve in that area. So please join us as we begin our journey today to further explore prematurity, where we are, and hear from the March of Dimes in that regard. So without any further ado, I want to turn it over to Erin Koppenbarger and Lori Appelkamp with the March of Dimes. So Erin?
Thank you, Joyce. Yeah, so World Prematurity Day on November 17th. Make sure you wear your purple and tag March of Dimes if you post on social media. So for our report card, it was really building on the 2022 Maternity Care Deserts report. The report card sheds further light on the state of maternal and infant health care by presenting the latest data on key health measures, especially in the maternal infant space. Even when families overcome obstacles to finding care, women and babies are still facing those poor health outcomes and grave disparities, making the U.S. among the most dangerous developed nations for childbirth. So like Joyce said, our report card actually comes out on Tuesday, so you all are getting a VIP first peek. Please refrain from sharing this information until the 15th. Kamisha will send out those slides to you then. Next slide, please. So if you did not know, March of Dimes' mission is to lead the fight for the health of all moms and babies. No income level, race, or county should determine if a mom or her baby get to survive pregnancy or the first year of their life. Next slide, please. A little background about March of Dimes I think can be helpful in understanding why we develop these reports. For over 80 years, March of Dimes has been funding research and practical application of that knowledge. As we were founded by FDR, who was afflicted with polio, our earlier days focused on vaccine research leading to the eradication of the disease in the US. We then shifted focus to address some of the biggest health threats to moms and babies with innovations like folic acid and newborn screening. So in 1940, FDR requested U.S. citizens to donate what they could to fund research for polio. Eddie Cantor, a comedian and humanitarian, coined the term March of Dimes when he urged people on his radio program to flood the Capitol with their spare change. Through this crowdfunding, Dr. Jonas Salk discovered the polio vaccine. In the 50s, Dr. Virginia Apgar joined March of Dimes. In the 60s, we began funding newborn screening, and then in the 90s, March of Dimes spearheaded the Birth Defects Prevention Act of 1998 and led efforts to promote the benefits of folic acid. With research still one of our main pillars, March of Dimes uses data to understand where our focus should lie. Now health equity is the main focus of our programmatic and advocacy efforts, and once we go through all the information today, you'll see why. Next slide, please. Now more than ever, March of Dimes needs partners in the fight for healthy moms and strong babies. The U.S. has the highest maternal death rate among the world's most developed nations. Among other developed nations, the death rate has been stable or falling, but in the U.S. it's getting worse. every 12 hours, a woman will die from pregnancy-related causes, and by the time our meeting is over today, 4 babies in the U.S. will have died. Next slide, please. The U.S. ranks 7th in the number of preterm births in the world. Just kind of let that sink in. I know for me, I feel so privileged to live in the United States, so it's difficult to kind of wrap my head around that and why we're still lacking in our health outcomes for our moms and babies. Next slide. The U.S. ranks highest in preterm birth rate in high-income countries. So you can see that really the only countries that are darker than the U.S. on this slide, or with a higher preterm birth rate, are the ones that have a lower GDP. Next slide. So preterm birth and low birth weight together make up the second leading cause of infant deaths after birth defects. We know that there are many health consequences of preterm birth, including developmental delays and chronic respiratory problems, to vision and hearing impairment. So having a preterm baby impacts families emotionally and financially. Next slide. Since we know that the U.S. has a high preterm rate compared to other developed nations, and prematurity is one of the leading causes of infant mortality, it's no surprise that the U.S. has a higher infant mortality rate than our peers. The U.S. has a 30% higher rate of infant mortality than Canada, which is the next highest of the high-income countries. Here we've compared U.S. maternal mortality rates with to the 10 countries with the highest GDP. So 8 in 10 maternal deaths are preventable according to the CDC. So if we if we stopped the preventable deaths from occurring, the rate would be 4.8 instead of 23.8 in the U.S. Okay. And not only is the U.S. lacking compared to our other high-income country peers, there's disparities within our country itself. So while 1 in 9 white babies are born prematurely, 1 in 6 Black women deliver their babies too soon. So out of 100 births, that's 5 more Black babies that die than white babies. It's clear that structural racism and barriers to adequate prenatal and OB care exist, especially for those disadvantaged families and communities of color facing health disparities. So if we weren't already sick of talking about COVID the last 3 years, we probably will be by the time I'm done talking today, so I apologize for that. In advance. You can see that women are getting more comfortable with the COVID-19 vaccine either before or during their pregnancy, so that's great. But you can see that, again, there are racial disparities with Black women not even reaching that 60% rate of vaccination. Pregnant women infected with COVID-19 have a 40% higher risk of preterm births. We see an increasing number of pregnant persons in the U.S. with chronic health conditions such as hypertension, diabetes, and chronic heart disease. We know that these conditions can put a person at higher risk of complications during pregnancy or in the postpartum period. So adding COVID to that is not a great thing. People who have those conditions, the risk of preterm birth rose 100% for women infected with COVID who had hypertension, diabetes, obesity. So with all that background knowledge, we have 2 clear goals: to end preventable maternal risks and deaths, and end preventable preterm birth and infant death. To achieve these goals, we know we have to end the health equity gap. So this slide's just a summary of prematurity in Oklahoma. In 1 week, about 915 babies are born, and 102 of those babies will be preterm. 76 of them are born late preterm, and then 13 very preterm. So I wanted to start with last year's report card so you guys can kind of see how we're changing each year. So last year we celebrated a better score on our prematurity report card. Well, no, not really. The score went in 2021 went up from a D minus, went up to a D minus from an F in 2020. So yeah, better, but still not great. Since 2014, our preterm birth rate has been rising with the exception of 2020. You can see those years are in dark purple, the years of the increase, indicating that the trend of the increased preterm births was significant. With the slight decrease in 2020 preterm rates, we are hopeful to see if our preterm birth rate would continue to trend down. Next slide. And unfortunately, we slid right back down to an F. So on our 2022 report card, you can see by the purple trend line, our increase in preterm birth is significant. 11.9% of babies in Oklahoma are born preterm. That's more than 1 in 10. So I want you all to humor me for a minute. If you can put your hands out like this, and not a lot of you are on video, so I don't know if you'll be doing it or not. But take away 2 of your fingers. Okay. If that counts for the babies, right? So more than 1 in 10 babies. Okay. It's a lot. Try picking something up, right? So like this, can't really do anything. It's really hard, right? So it's a lot harder to be productive. When 2 babies out of 10 families are born with health issues, that's a big burden on them emotionally, physically, financially. That can seep into other areas of their life, affecting their jobs and their friends and extended family. The cost associated with 1 preterm birth in Oklahoma is about $54,000. In a year, all preterm births in Oklahoma is $289 million. And across the US, it's approximately $25.2 billion. Next slide, please. So based on our data, the US earned a D+ grade for preterm birth, with the preterm birth rate increasing to 10.5%, the worst rate March of Dimes has ever reported. Now more than ever, a lot of factors are fueling this crisis, including racism, as I'd mentioned before, poor maternal health, and socioeconomic status. As the crisis becomes worse for our most vulnerable, we need to explore and address these causes with real action. The preterm birth rate increased 4% among all races, except for in 2020, the preterm birth rate has steadily increased since 2014, with worsening outcomes for Black and American Indian Alaska Native women and their babies. So the 2022 report card assigns grades to 100 cities with the greatest number of live births from 2021. So the grades are assigned by comparing the preterm birth rate for 2021 of that city to the March of Dimes goal being 8.1%. So you probably could have guessed that since Oklahoma scored an F, that our 2 largest cities would too. So Tulsa had a preterm birth rate of 12, and Oklahoma City's rate is 12.4. We don't have any in the A, B, C, D, unfortunately. Go ahead, next slide. Thank you. So our 2021 report found that Black women were 39% more likely to deliver a baby preterm than any other race or ethnicity. Here you can see the bar for Black women is a definite outlier to the others. In our 2022 report, sadly, Black women are 45% more likely to deliver preterm than all other women. That increased 6% over the previous year. And we know that education and income are not protective factors for pregnancy outcomes in Black women. A Black woman with a college degree is still more likely to deliver a baby prematurely than a white woman without a high school diploma. So this slide is similar to the last in that it has preterm birth rate disaggregated by race and ethnicity. However, you can see the disparity ratio. Um, the disparity ratio compares the racial and ethnic group with the lowest preterm birth rate in Oklahoma. In Oklahoma's case, that's Asian Pacific Islanders with a rate of 9.9 compared to the average of all other groups, which is 12.2. So again, that gives us a disparity ratio of 1.23 for Oklahoma. We want to get closer to a 1. The closer we are to a 1, the less disparity. The rate for the entire US is 1.26. So surprisingly, Oklahoma is at the better side of this one. But of course, we don't want to settle for that. It's obvious that there's persistent disparities that exist across maternal and infant health, most significantly among Black and American Indian Alaska Native families. According to the CDC, women from racial and ethnic minorities and other socially disadvantaged groups, like those in underserved areas, have faced barriers to accessing maternal health care. Of course, the COVID pandemic caused reductions in services such as public transportation, increased childcare challenges, exacerbating existing barriers to accessing care, and likely affected women from these groups more than others. Slide. So you can see that in our 2021 report on infant mortality, it was much higher than the US rate, 7.1 versus 5.6 for the US. But we also have very inconsistent trends in infant mortality in Oklahoma. We're kind of all over the place, 7.9, 6.7, 8.2, down to 7.1. So we don't really have a clear picture of what infant mortality is going to look like moving forward. Next slide. So the good news is that our infant mortality rate has decreased based on our 2022 report card. Unfortunately, it's not a significant trend, and we are still higher than the US average for infant deaths. But again, 5.7 is a lot better than 7.1 from last year's report, so I'll take a win on this trend any day. However, Black babies in Oklahoma have an infant mortality rate of 13.8, which is 119% higher than white babies. Okay, so in 2021, our report card had a tool called the Social Vulnerability Index, or SVI, which is measured by socioeconomic status, household composition and disability, minority status and language, housing type, and transportation. So you can see that the counties with the darkest purple have the greater risk of experiencing poor health outcomes during a public health emergency. So for 2022, this is the newest feature for the report card, the Maternal Vulnerability Index, or MVI, which is replacing the Social Vulnerability Index. The MVI is a tool to identify where moms in the US are vulnerable to poor pregnancy outcomes and why. So versus just the social vulnerability, it's more maternal health based. So it's a county level, national scale tool, and it's the first of its kind. Much more relevant to our cause here in maternal and infant health. The MVI explores 43 indicators across 6 themes, which are reproductive and physical health, mental health and substance use, general health care, socioeconomic determinants, and environmental factors. It's scored on a scale of 0 to 100. In this case, we want it to be 0. And you can see that the majority of southeastern Oklahoma has a very high MVI. And talking nationwide, while some parts of the country are more vulnerable, 4 out of 5 counties have some aspect of maternal health that can be improved. The magnitude of racial disparities in maternal vulnerability is profound. Black women are nearly twice as likely to live in highly vulnerable counties than their white counterparts. But the next sentence is really important, so I want you to really pay attention to what I'm saying. Black women in the lowest vulnerability counties, so not a lot, they're not vulnerable, are still at higher risk of death and poor health outcomes than white women living in the highest vulnerability counties. So as far as clinical measures go, in 2021, low-risk C-sections were lower than the national average. However, our inadequate prenatal care was higher than the rest of the U.S. Black women, followed by American Indian, are most likely in Oklahoma to have a low-risk C-section. So by reducing the overuse of this procedure when not medically indicated, we could prevent more maternal deaths and illnesses. So in 2020, for our 2022 report, low-risk C-sections went down 0.1 point from our 2021 report, but inadequate prenatal care decreased by 1%, which I was surprised just because of the pandemic. We weren't really sure. People not getting it's harder to get care, things like that. Black women do have the highest percentage of low-risk C-section deliveries in Oklahoma at 27.3, followed by American Indian at 26.3, Asian Pacific Islander at 25.7, white at 23.9, and Hispanic women have the lowest percent at 22.2%. And again, we see the disparities for Black women in prenatal care. Black women are 65% more likely to begin care in the 5th month of pregnancy or later, or attend less than 50% of doctor visits than white women. So 65% more likely to get inadequate prenatal care than white women. So this feature was not on the 2021 report and will be included in the 2022 supplemental report card, which examines data specifically by race and ethnicity to identify health disparities. As most of you know, Healthy People 2030 objectives are set nationally by the U.S. Department of Health and Human Services using data-driven objectives with the goal of improving health and well-being. So many of the Healthy People 2023 objectives are specific to the prevention of pregnancy complications and maternal death, as well as improvements to women's health before, during, and after pregnancy. So these graphs show where Oklahoma falls for each objective, including preterm birth, infant mortality, unhealthy weight before pregnancy, and then low-risk cesarean births. So for preterm birth, the objective is less than 9.4 per 100 births. You can see that goal depicted by the faint dashed line on the first bar. The worst rate is 15 in the US, while the lowest is 7. So Oklahoma falls at 11.9. The infant mortality goal is to be less than 5 infant deaths per 1,000 births. Again, Oklahoma is higher than the Healthy People 2023 goal, coming in at 5.7. Ideally, less than 52.9% of women will be at an unhealthy weight before pregnancy. Oklahoma women came in over 11% higher than the goal at 64% at unhealthy weight before pregnancy. And then low risk C-sections have a very wide range nationwide, with the best score of 17 and the worst at 46%. So I thought that was very interesting to see the big gap there. Oklahoma is just over the 2030 goal of 23.6 at 24.4%. So the U.S. has not moved the needle on maternal infant health and equity. March of Dimes implements programs, education, research, and advocacy to support families and improve outcomes. So here's just a few things March of Dimes does based on the data from this report. Our newest research focus is on understanding and preventing late preterm births, as they account for the large majority of preterm births. In Oklahoma, it's about 75%, maybe 80%. So this also ties to our work to reduce adverse outcomes by non-medically induced inductions and C-sections. And then Compass by March of Dimes is a new app coming out that will support new and expecting parents with resources to help navigate the parenting journey. We're also working to increase access to our evidence-based programs. So supportive pregnancy care is a group prenatal care framework designed to improve high quality prenatal care, education, and social support. It's been shown that if people have care by a provider and then also with peers in a group setting, that they have better outcomes. So this will be implemented in Oklahoma OB offices in 2023. We also have NICU Family Support Program that helps families through that really tough time by improving the NICU patient and family experience. Implicit bias is one of, in my opinion, our best programs that we offer. As I talked, I'm sure you all gathered that racial disparities in Oklahoma run really deep. This training for providers offers insight on biases specifically in the maternity care space. We also offer this training to medical and nursing students. And of course, we already have some great things coming down the pipeline in Oklahoma as far as advocacy goes. We're really excited for our postpartum Medicaid extension and doula coverage. We do a lot of advocacy. So since a lot of this stuff is already happening, let us know if there's things that we need to advocate for in Oklahoma so that we can put that into our advocacy day that happens in March. And then next slide. As I'm now working for March of Dimes in St. Louis, I put Lori's info up there. She's the local Oklahoma contact, but I am still available if anyone has further questions. I love working with you all, so you can't get rid of me. And if you want to take 30 seconds to join our advocacy network, you can scan that QR code to help us move the needle. I know I talk really fast, so I think I went through that really fast. So we have times for questions, comments. I would love.
Great. Thank you so much, Erin. We really appreciate it. That was a very good presentation. Wish the numbers were better, but we'll keep working on that. We aren't giving up, and we're going to keep getting the messages out and follow those evidence-based practices to try to get that number down much further. Preterm is a hard row for both mom and baby, and so we'd like to lower that. Any questions for Erin?
I will take this time to talk about our low dose aspirin campaign for the prematurity work group. So we are working on a grant to get someone to solely work on this program. There's nobody has the time, right? So we need someone fully just to work on that. We have talked to Medicaid, and they are thinking about covering low dose aspirin for their clients, just because it's a very simple thing to do. And I think that's pretty much the main things. We're developing education materials for providers as well as patients, just to get everyone on the same page, because a lot of providers are hearing different things. But of course, low dose aspirin can prevent preeclampsia, which can prevent prematurity. So really working on that.
Yes, and that is a great plug for that. I know there's a group of partners trying to all work together on that, get that message out. It's one item that we think can be done to reduce prematurity and also preeclampsia? Yes, Lisa. Lisa has a question.
Yes, Miss Erin, I was wondering if you had any information on approaches different for rural areas versus urban, or if we even had a breakdown statewide of those numbers. You had a lot of info, so I apologize if you did have that and I didn't catch it.
So I didn't really focus very much on our maternity care desert report, but that is out. And we're hoping to work on a mobile health unit. So that might be something that could, bring two people instead of having them to have to travel. So,
Right. Right.
yeah,
Thank you.
you're welcome.
I actually had a question about the disparity index. I know that you mentioned that it was at 1.23, which was actually lower than the overall rate for the United States, which was 1.26. But is that more so because all groups in Oklahoma are relatively doing poorly? And if so, how do you contextualize that so that a layperson doesn't look at the disparity index for Oklahoma and think there's really not a lot of disparities versus, we just really
United
have
States,
poor
right.
outcomes among several of our groups?
Yeah, that's a good question. So if we, yeah, thank you for pulling that slide up. So we have the Asian Pacific Islanders actually have the best rates in Oklahoma, and everyone else besides Black women together 12.2. So I'm kind of fumbling over my words because it's a tough thing to kind of hammer down, right? But if we think of it as we want to get closer to 1, there's still a ways to go, right? That's why I kind of mentioned, like, we can't really settle for just being better than the US in this. I mean, we don't have we know that disparities exist. And so I think maybe it's just because our Asian Pacific Islanders did so much better that possibly that kind of skewed it a little bit. That's a great question. If you want to drop your contact info in the chat, then maybe we can discuss it a little further because I'm really interested in that.
Okay, thank you.
Yeah.
And we do have a comment in the chat. Is it because the white rate is worse in Oklahoma? Like, could that be a possibility?
Yeah, I mean, absolutely. Yeah, the white rate could be a lot better in other states. That's why I was saying, like, since the Asian is a little bit better than the white, that might make it harder as far as the ratio.
Also, I believe Becky has a question. Becky, do you have your hand up?
Yes, yes. Hey, Erin.
Hey, Becky.
So of course I'm going to have a breastfeeding question. So,
Yes.
so of course with our high rate of preterm deliveries, and we know, and yeah, we'll have much better outcomes if those babies are, fully breastfed. So any just overview of what March of Dimes is doing to support breastfeeding or use of donor milk in that population?
So we do support, the advocacy that's going on to have it really across the country, Medicaid coverage of the pasteurized donor human milk in the home setting. I don't think we have any specific data on it, at least not in our reports. But that's something that me specifically I work on a lot because you know that I care about breastfeeding. But I can see if I can get some data for you, Becky.
Yeah, it would be nice to see March of Dimes maybe track yeah, and do some reporting on that too. Where do we have first food deserts, especially in the preterm population? So
Absolutely.
Right. Any other questions for Erin or
You guys have
comments?
some tough ones.
The chat is clear at this time.
Okay. Well, Erin, again, thank you so much for presenting to us today and giving us the information. And we know where we need to improve further and where we're going. So it looks like we have a game plan moving forward, and we'll try to make that look better in years to come for our moms and babies. So thank you so much for sharing with us today. We
Absolutely.
appreciate
Thank
you.
you.
All right. Well, next we will move to our work group year-end updates and see what's going on there to help reduce infant mortality. And we've just heard about kind of what's going on with preterm birth. And now we're going to hear what's going on in the work groups. And Dr. Lilly is going to be talking to us about what's going on in maternal mental health.
Good
So,
morning.
Dr.
Thanks,
Lilly.
Joyce. Can you hear me okay?
Yes, we can hear you good.
Okay, all right. James is not able to be with us this morning, so I'll update us on the maternal mental health work group. We have been meeting monthly on the fourth Tuesday of the month, or the last Tuesday of the month, I'm sorry, from 2 to 4 p.m. And so before I go any further, I want to invite anyone who'd like to join us to reach out and join us during those times. We have a great time looking at this area and trying to get some things moving. We have been working to create awareness of supports for families and who are experiencing maternal mental health issues. And so James keeps a regular report of the different work groups that are available, support groups available on the PSI Postpartum Support International site. They have a plethora of really great support groups, and they've just added another one. And it is called a birth trauma support group. All of their support groups are led by trained peer facilitators, but this particular group is for any birthing person who's experienced trauma, mental and or physical, during childbirth. And so we think it'll be a great resource to add to the list for our maternal mental health work group. Next slide. One thing that we are very excited about is that we have been able to, with support from Maternal and Child Health, we were able to have another training around perinatal mood disorders and the components of care that is put on by the Postpartum Support International Work Group. And we had that training in October and are proud to announce that we had 40 participants that completed the training. And we are very hopeful that we'll have most of that number certified within the next 6 months. The training was an excellent training. It's the second one that we have done in the state of Oklahoma in the last few years. And we look forward to being able to continue to increase the capacity of our workforce for dealing with maternal mental health issues. So thank you, Joyce, for supporting that. And we look forward to continuing to increase the capacity of our workforce as well. Next slide. In looking at, we've been stepping back to take a look at what's going on across the nation in this area as well. And 2020 Mom takes the lead in this area in a lot of ways. So we often look to them to see what they're doing so that we can see if there are things that we can begin to implement here in Oklahoma. And this issue brief has some areas that we wanted to share as highlights that we will be looking at and discussing within our work group. So some of the highlighted material is that maternal suicide is a leading cause of maternal mortality across the United States, which is very distressing. And it's an area that we will begin to talk more about and try to get numbers for Oklahoma in. The briefing also underscored the need that when screening for perinatal mood and anxiety disorders, that anyone indicating suicidal thoughts on a screening tool should have an immediate next step assessment, and they recommend doing that with the Columbia Suicide Severity Rating Scale. We want to talk more about that and work to increase that within our training for professionals that we're working with as well. So we'll dig into that a lot more this next year. The brief reiterated that the importance of maternal mortality review committee in reviewing pregnancy-associated deaths and identifying state-level opportunities for prevention. This is a way that we can really begin to look at how we can impact this area. And then we always want to work on training our healthcare providers and all of our staffs on suicide prevention, but also awareness and understanding of the impact of maternal mental health disorders. We are reviewing our work plan and making some further updates so that we can continue to increase awareness and supports here in Oklahoma. And that's all. Any questions?
Any questions for Dr. Lilly? Or comments?
Or comments, yes. We would like for you to join us if you are interested in this area. We are working to increase the awareness of maternal mood disorders in the state of Oklahoma, as well as resources that are available here, and working to increase those resources available to families. So if you're interested in that at all, please come and join us, reach out and let us know.
Great. Thank you so much, Dr. Lilly. It's
Thank you,
really good
Joyce.
news coming out of this work group, and we appreciate everything that's being done for our moms in this regard. So look forward to more trained and certified
Yes.
CMAD, and
Yes.
that's going to be a really good thing for Oklahoma.
Yes, very
All
much
right.
so. Thank you.
Thank you. Okay, and I believe Denise Cole is next going to speak about infant safe sleep.
Yes, and again, James is normally the one who updates our work group, updates everyone on our work group activities. But like Dr. Lilly said, he is unavailable this morning. So one of our updates involves the SIDS and Safe Sleep Awareness Month efforts that were put out. This was in October, so last month. One of the resources that was shared by the Oklahoma State Department of Health were 5 videos that were produced by Charlie's Kids that we were able to co-brand with the Oklahoma State Department of Health logo, and those videos were shared on the OSDH Instagram and Facebook pages, and then reshared by other of the city and county health departments. But these videos are pretty informative, but nice that they are short, and so less than a minute long, where they can focus on the importance of safe sleep, normalizing night waking. So it's making sure parents are aware that it's not unusual for newborns to awake during the night. I'm talking about nighttime breastfeeding safely, and supporting getting their baby back into their bed safely, and avoiding co-sleeping. So it's a great resource, hoping that new families are able to view and absorb that information. And then on the next slide, going over some of the other safe sleep awareness activities. There was an interview with Natalie Cruz on News 9, where James was able to mention the new AAP guidelines and provide some anecdotal reports, or he provided anecdotal reports of people seeing the segment, so it was actually viewed. And unfortunately, the information that they ended up editing down into the segment wasn't completely about the new guidelines. But there is the message out there, and hopefully can send people to review those new guidelines. There was also a radio interview with Caitlin Mills for KOSU that was a little bit more informative. And as you can see, there's a link there to that radio interview. And it did provide links to the State Department of Health Safe Sleep webpage. So again, hopefully creating awareness and guidance for resources. And other activities that James has done over the last month And again, this is his work, so I don't want to take credit, and I don't know much more than what he's provided here on the slides for us, but he has been busy in doing a lot of training, mostly to home-based coaches and in-home visitation program staff. So hopefully that will continue to get the message out to new families about appropriate safe sleep practices. But on October 10th, he did a training for 23 safe care coaches on the new guidelines and how to specifically address those concerns when they do go out and coach and counsel families. On October 20th, at the Integris Women's and Children's Leadership Meeting, and this was a system-wide for all of the Integris hospitals across the state who deliver babies, but making sure that they are up to date with their hospital policies and how the nurses model safe sleep practices for new families while they're in the hospital before they go home. Hopefully the only 2 Integris hospitals that are not currently certified with Cribs for Kids will be able to complete that process. So all of the Integris hospitals will then be certified. On November 1st, he did a training for a prenatal course in Okmulgee. And then November 2nd, I'm training with Choctaw home visitors with a couple of programs there specific for the Choctaw Nation. So he's doing great work and getting that information out there. And I believe that was our last slide for Safe Sleep.
All right. Thank you, Denise. Safe Sleep's making progress across the state, and that's great to see. Any questions for Denise or comments?
There is a couple in the chat. What about having him come to staff meetings for home visitors? If so, can I get a contact info? Amanda, we'll definitely get that information to him and have him follow up with you directly.
Thank you.
And we do also have quarterly meetings. We usually meet the Thursday prior to these Preparing for a Lifetime stakeholder meetings. I know that Janet sent out the invitations for those meetings for 2023 yesterday. If you are interested in participating in the work group and did not receive one of those invitations, feel free to reach out to me. I'll put my email in the chat and we'll make sure that you get added.
Wonderful. Thank you, Denise. Okay. And next we have infant injury prevention. Are you taking the lead on that, Lisa?
Yes, ma'am.
All right.
Good morning again, everybody. Excuse me, my name is Lisa Rhodes, and I'm the program manager for Oklahoma Child Death Review Board and one of 3 co-leads in the Infant Injury Prevention Work Group. Some of our updates include we have initiated a grandparent training toolkit, whole sort of little, it's gotten bigger than we thought it would, and that is a good thing. We've realized the need, and so some of the progress we've made is we were able to get a survey out to grandparents through a couple of our partners at DHS and Sunbeam, and we asked them about what different kinds of information they needed, what style of training they would like. And most that responded that they wanted in-person followed by on-demand trainings. And the top topics that were picked were on safety, child development, mental health, discipline, and connecting with the grandchild. We're also consulting with additional partners and other parent-grandparent boards and groups. Sorry for not having reader glasses. I can't not read my notes here to see what else I needed to let you all know. Oh yeah, so we're in consultation for both want their input on programming as well as implementation. So the survey was about implementation, but we are still in the process of deciding programming and curriculum and want to ensure that it fits the needs of Oklahoma's grandparents. After that, kind of all things purple, our purple progress is there was a home visitation anniversary celebration that I was able to attend, and a lot of our partners who are providing purple was fun to be able to go to that. 25 years of home visitation, and often been able to supports the prevention success when none of those families that are involved in home visitation programs end up being in my program's realm. So we know prevention home visitation works, so it's fun to celebrate that and continue partnering with them and delivering the safe injury prevention messages that we need delivered. Click for Babies. Sorry, jumping ahead. I also attended the Fatherhood Summit that was hosted by my agency, and we are looking for ways to continue the barbershop project. The home visitation anniversary celebration included the inaugural Mildred Ramsey Award, and it went to Marquise, who has been doing our Purple Barbershop project in the Tulsa area. So we want to continue that, especially and continue Mildred's legacy of helping babies find their first, celebrate their first birthday. So we are continuing to find ways to make sure that continues. Click for Babies this year is going to be a little bit softer launch as the National Center itself kind of transitions over to using booties instead of hats to help support the safe sleep message. We have enough states no longer request for the hats either, so hospitals can request the hats from the National Center. They can ask us if they'd like, but we would then connect them with the National Center for the hats. I don't know if everyone at this meeting is aware that a few years ago, we had an intense reaction to our call for hats and still have some in storage. And so we emphasize soft launch on this slide. We also have done a recent count and know that there are only 4 hospitals, delivery hospitals in the state that are not participating in Purple. And they are all associated with tribes or Indian Health Service. So got to think of a different way to connect with them. Mainly just starting out with sharing data is kind of what we've been thinking, but don't want to assume there's no way to get them to participate in Purple without at least trying to have a dialogue. We also, Oklahoma was well represented at the National Center for Shaken Baby Syndrome's annual conference. CDRB staff was able to go. A work group member, co-lead Brandy Woods Littlejohn was able to go. She is out of injury prevention services at the health department, and family support and prevention services also had a contingent that was able to go up to the conference in Philadelphia. And so looking forward to hearing feedback from my staff as well as our work group co-lead and finding out what's happening at the national level that we can't utilize to help us continue to educate the rest of the state about Superior to Purple Crying. We also, the RAC card is specific to being in like providers' offices where families would be going for services, and it's actually titled Parenting is Hard, You Are Not Alone, and covers such topics as Purple Crying, safe sleep tips, as well as the Parenting Warm Line number. The edits are complete, including Spanish translation, so we're just waiting on the print job and the final electronic copy for sharing and working on a distribution plan for that. Next slide, please. We did decide, since we'd been in action for so long, we requested some data from injury prevention partners. And unfortunately, it still does demonstrate a little bit more work to be done because we've seen a steady increase since about 2014. And get my other notes so I can explain these properly too. Infants in 3-year rolling rates due to low counts. That's why we have them in these 3-year clusters down here. The lowest death rate of 4.4 per 100,000 was in the 2012 to 2014. Unfortunately, increasing since, peaking in the 2016-2018 time period. Doing a little bit of my own notes that I didn't say when we had this meeting, or no, I probably did. Just would like to point out that lots was happening nationally, socially, lots of upheaval for lots of people, and don't know how much that might have played into all the factors that affect abusive head trauma prevention. Next slide, please. She also prepared for us deaths by race and ethnicity with 10-year rates. Highest group is Black non-Hispanic, 18 per 100,000. 5-year rate is even higher at 28 per 100,000. So definitely some additional work to do there. Don't want to leave us with too distraught a message. So next slide, please. We do have information that demonstrates since we implemented Peer to Purple Crying in Oklahoma, there has been a reduction overall of abusive head trauma fatality rates. And so we have made some progress, but looking forward to continuing ways to increase our progress. Left out one note, another portion of Purple project is ensuring our providers are supported and we're getting a good communication line with them on what their needs are and how we can support them in the Fidelity implementation portion of providing the education. Lastly, and let me make sure I get the correct link. One of our partners works. It's not to work now. There is a Great Health Handbook, and it is utilized by Child Care Service. Isha, I may need you to find this. There we go. Let me see. Sorry, I can't juggle. Got to pull Teams back up. It goes to child care centers. And best practices for the children in the care related to injury and illness prevention, treatment, and special health care needs. It is also used by the Child Care Warm Line and schools, community colleges are using it in their early childhood curriculum courses. And it was the version that is in the chat box was published in 2015. The health department is working on updating it now, and lots of different partners, including epidemiology and communicable diseases divisions, are all working together on it and looks to be done in 2023. Any questions? I see one in the box.
This is Amanda, and I tried to click on the link and it didn't come up. I don't know if I'm the only one that's happened to, but there might be something wrong with that
Looks
link.
like it cut off. So when the next group pops on, I will throw it in there. I want to answer any other questions that might be up, but I will get that in there, I promise.
Great. It looks like Kathy has a question.
What was going on 2012 to 2014? That rate was so low, some different issues and how these were documented or nationwide push. No different issues in the documentation. It's all a strict death certificate pull from my understanding, not being the one who pulled the data. So we need to look at it as well too. That's what made me look at least what was going on nationally, politically, that may have influenced additional challenges in our families making the best choices. Thank you, Kamisha. She got the updated link put into the chat box.
Yes, updated link is in the chat box. You can utilize that. Any other questions or comments for Kamisha? For Lisa? I know a lot is going on in the infant injury prevention work group. You have many activities and items that are moving forward. So I want to thank our infant injury prevention work group and Miss Lisa for presenting today. And I love that blanket behind you.
Oh,
Wow,
thank
that's
you.
beautiful.
Thank you, thank you. It was my treat for, or my carrot for returning back to the office.
Ah, very nice. Thank you.
Thank you.
Okay, and next, I believe we have interconception, preconception with Jill.
All right, good morning. I don't have a slide that's fancy like everyone else's because our work group meeting is this afternoon. And so our major updates are going to come after this afternoon. So I just wanted to give you some highlights of kind of what we're going to be discussing and where we're at, which are similar to the last meeting we had, but we're continuing to watch the Medicaid expansion to see if having increased coverage translates into people accessing services. Because we also, as you heard Aaron say earlier, have the maternity care deserts, which means that the providers that typically provide preconception, interconception care are the same ones frequently that do prenatal care and deliveries. So if we don't have a provider in the area, then just having access to insurance coverage doesn't necessarily translate into having access to a provider. So we're watching for some numbers to come from that yet. We're also providing some input into the RFP process. I think most of you have heard that the Healthcare Authority is releasing requests for proposals for the MCOs to do managed care as part of Medicaid expansion. I heard yesterday that the dental RFP has been released and closed, and the medical one is still behind. Excuse me, and they have not released it yet. So we're working to try and provide input when we can to make sure that the preconception areas of care are included. Also, I wanted to point out, we'll talk about this afternoon, the HELP task force, the task force that the governor put into existence shortly after some of the laws changed in Oklahoma, made some recommendations the end of October. They released some recommendations, which some of those overlap with priorities for our work group, specifically addressing the maternity care deserts, looking at some funding that the health department has for childbirth and care options, raising the federal poverty level for senior care income eligibility from 138 to 205% of federal poverty, and extending postpartum coverage from 60 days to 12 months. Looking at supporting full practice authority for APRNs in the state, and supporting the fatherhood initiatives that are already in place. So those are the recommendations from the task force that kind of directly relate to the goals of our work group. So we'll be discussing that this afternoon. In our meeting, we'll be looking at a work plan for next year and prioritizing activities. So we'll be discussing some of those things. So we'll have much more to share at our next meeting. But I also wanted to point out some other things that we usually report on. We usually talk about the Focus Forward trainings, which are in combination or collaboration with the Healthcare Authority and an OU Medical Center. And those trainings have been scheduled again. There's 4 more before the end of the year, with the first one being this Saturday in Ardmore. But if you're interested, you can, I think it's for Focus Forward Oklahoma. I can find the link, but I think it's Focus Forward Oklahoma, or okay. If you have anybody that needs information on long-acting reversible contraception, this is for providers who need to learn how to insert IUDs and Nexplanon, and also for like office staff or clinics staff that might want to know more about it, and billing people to, they have a wide curriculum. So we're happy to say that those trainings are back. They were put on hold during COVID when nobody could get together, but now they were able to get some scheduled again. So that's exciting. I'm happy to report that we do have some preconception health messages and maternal mortality messages that we're putting out through our Cox Media contract. And the report that we got last week showed that these messages are still doing very well. There's a lot of people interested in those messages. So that's exciting. Another thing that we're going to talk about this afternoon is messages that we want to make sure and get out next year. What are our priority messages, and how do we want to do that? So that'll be part of our work plan for this afternoon also. As far as the family planning program, which does provide preconception education, healthcare, and counseling through our county health departments, I'm very happy to report that Jenna ran a report for us, and from January through September, we have seen 21,614 unduplicated clients, which is a lot lower than we have been in past years. But compared to last year, our total for last year was 23,641. And so through the first 9 months, we've almost seen as many clients in our family planning program. So that's great news that we're on track to surpass those numbers by a long shot this year. So I want to give kudos to all those working in the counties that are helping to bring the family planning services back up to our normal level. And then as I mentioned earlier, we have the fatherhood projects that some of our staff are involved in the counties, and our work group is looking at how we can support fatherhood activities and how that relates to preconception and prenatal care. And then I'm happy to report that most of the districts in the state are working on adding maternity services. We have some active maternity clinics going in District 8 and 9. District 5 added maternity services at the beginning of November. District 8 did have maternity services, but lost our APRN, but they have hired a new nurse midwife that I met over the weekend, who I think will do a fabulous job in bringing those services back to District 8. District 3 is working on getting oriented and getting some agreements in place. District 1 is looking at the beginning of the year. And I don't have a timeline for the other couple districts, but everybody's in discussion. And so that will, I think, address the maternity care deserts that we've mentioned today, because a lot of these counties that we're providing services in are counties where there is not another prenatal care provider. So I think that we'll make some strides in addressing early entry into prenatal care and quality prenatal care that's available in our counties. And I think that's the highlights for us. We'll have more next time after we develop our work plan today.
All right, thank you, Jill. Good work going on. Any questions for Jill or comments? Okay, thank you. I think next we have Crystal with tobacco.
Good morning. Thank you for having me. Can you hear me okay?
Yes.
Wonderful. So I, like Jill, don't have slides. I have my cute title slide, but that's because, as many of you know, the tobacco work group has been a little stagnant lately. So my goal for 2023 is to revitalize that and to bring that back. Starting in February, my plan is to meet bi-monthly. It'll be the first Thursday of every month from 10 to 11. I stepped into the lead cessation role in around April, actually. And I've had that opportunity to do a lot of listening. And I have some pretty good ideas on ways we can help, whether that be navigating the cessation conversation, navigating competing priorities, if you have maybe reluctant patients or clients, or even making sure clinicians feel comfortable in having that conversation. So I would love for people to join in that work group so we can really elaborate on these needs. I'll be more than happy to put my email in the chat if it's not already there. Misha, you're so good. It's already there. But please don't hesitate to reach out to me, or if you have a specific need, I would love to help you with that as well. I do have a couple of tobacco updates for the state that you may be interested in. Most recently, the BREFAS data was released by the CDC. If you're not familiar with BREFAS, that's the Behavioral Risk Factor Surveillance System data. It reports that Oklahoma smoking rates have declined significantly. We're down to 16.9% as a state, which is great. Nationally, though, the rate is at 12.5%, so we still have a lot of work to do. And then there are two programs that I want to talk about really quickly. The first one is an incentivizing cessation efforts study. This is a partnership between the TSET Health Promotion Research Center and the Oklahoma Tobacco Helpline. And what it's looking at is evaluating whether incentives based on the OTH interventions, will increase smoking cessation rates in comparison with the standard OTH treatments amongst pregnant people. So there are a few eligibility requirements. One is they have to be insured by Medicaid. They have to be equal to or less than 25 weeks pregnant, and then they must be enrolled in the OTH cessation program. So I can drop a link into the chat if you have anyone that is interested in that, or you want to promote that within your individual facilities. I know they're actively seeking participants. And then additionally, if anyone is interested in cessation services at this moment, historically, the helpline provides 2 weeks of cessation, nicotine replacement therapies, things like that. Right now, that's expanded to 8 weeks, and that is through November 30th. So if anybody calls the helpline, they can get 8 weeks for free. So short and sweet with tobacco right now. I hope in 2023 I can bring more to the table, but does anybody have any questions? Or maybe they have a need that they want to talk about?
Any questions or comments for Crystal? All right, well, thank you so much, Crystal. We're so glad to have you on board and moving forward. So thank you for all you're doing. All right, so I think we're coming up to our closing time. Before I do, however, oh no, sorry. Definitely, breastfeeding has some good news to share, and also some new stats. So we definitely want to hear from our breastfeeding work group, and we have Becky, who is going to lead that presentation. So Becky.
All right, thanks, Joyce. So yeah, Kamisha, or whoever's doing the slides. Yeah, thanks. So yeah, just a little bit of updates with Chickasaw Nation. We just actually did our first in-person baby-friendly mock survey earlier this week, our first one since COVID. So over 2 years since we've actually been inside a hospital. So it was really fun to do that. And they're actually preparing for their baby-friendly redesignation on-site visit the end of this month. So kudos to Chickasaw Nation. Also, just a reminder to save the date. We have our 11th annual Becoming Baby Friendly in Oklahoma Summit that is scheduled for Friday, February 24th in the Oklahoma City area. Sarah's still, kind of nailing down the location, but I think it's going to be at Metro Tech where we had it last year. And then, and our topic will actually be kind of pertinent to our topic today, and that's breastfeeding and baby friendly in the NICU setting, and looking at recommendations for improving breastfeeding outcomes in our preterm and NICU populations. So, and Sarah included all this just to remind everyone of some of the breastfeeding education options that we have. Of course, thank you, COVID, and Jacqueline, who's on the in the meeting today. We developed the 1-hour prenatal education for families to take to help hospitals meet the prenatal education requirements for baby friendly. I mean, it's on our website and it's free and freely available for anyone. There's even a QR code you can print out like a little flyer and give that to families and patients. And then just reminders of the other offerings that we have, we continue the 1 day Making Breastfeeding Easier, and we have our new offering, Making Breastfeeding Easier for NICU Families, which is, we're really excited to launch that this year. Of course, our 2-day in-person class, which is Breastfeeding Basics and Beyond, and all of the health department home visiting staff are required to attend that course. So that's given quarterly, twice in Oklahoma City and twice in the Tulsa area. And then, you know, our online trainings, our new provider course as well, to help our hospitals that are either working towards baby friendly or currently baby friendly designated. So next slide. Thank you. And just, yeah, as a reminder, oh, my little percent, oh, there it is. I forgot to take the animation off there. So just to remind everybody where our baby-friendly hospitals are currently located. So we do have 11 baby-friendly hospitals, and 36%, approximately 36% of Oklahoma babies now are born in a baby-friendly hospital, which continues to be significantly above the national average of 27%. So we are quite proud of that, and then continuing to work on recruiting new hospitals to join the pack. Next slide, please. Yeah, so this is just a reminder of our new 1 day offering for breastfeeding in the NICU, and the information that's covered in that, and it is approved for nursing contact hours. So lots of videos in there as well. So next slide, please. And then, yes, our Oklahoma Mothers Milk Bank, the demand happily continues to increase. So the need for milk donors around the state and in surrounding states continues to increase. So our staff is really, the Milk Bank's team is really working hard to meet that need and continue to recruit new milk donors. And, you know, one just kind of anecdotal bit of information that Holly shared with me earlier this week, and Holly is our donor coordinator and community outreach, with all the information education that we've been doing around perinatal loss and donating milk after either loss of a pregnancy or loss of a baby. We've gone from maybe averaging 6 to 8 bereaved donors a year to, so far this year, we've had 40 bereaved milk donors. So that's not saying that we've had more losses, but just more awareness that that's an option for those mothers that have either lost, you know, a pregnancy or lost a baby and want to become a milk donor in memory of their baby. So that's a very special subset of our milk donors. Next slide, please. And yes, excitingly, just this week, the Healthcare Authority budget was approved, and the benefit now to cover Medicaid for babies with a medical need in the home setting is in that budget. So we're just waiting on kind of final rules and regulations from the Healthcare Authority so that we know how to implement that. It will require a provider order or prescription stating, you know, that the milk is medically necessary, and will be provided by our Oklahoma Mothers Milk Bank. So we are very, very excited about that. And yet again, another, as we want to meet that need. So another call to help us recruit milk donors for the Milk Bank. Next slide. I think I have just a couple more here. And as we've been working through COBA, and I know Heidi's on here, the executive director for our Coalition of Oklahoma Breastfeeding Advocates, but we've been working with the Department of Corrections. We had, I've never been inside a prison before, so we had a visit to the Mabel Bassett Correctional Center and met with the warden who's there in that picture. And that's from the left, going to the right, that's Frank Lawler, who's our logistics coordinator at the Milk Bank, Heidi Russell, who's the ED, and then Heidi can put in the chat box because I'm going to blank on, she would remember everybody's name much better than me. That is the warden for Mabel Bassett. There's me, and then Senator Carrie Hicks, who was a real proponent and really helped us make the connections to get this program launched. So the DOC is finalizing kind of their pumping policy, but by the 1st of next year, we will be able to support any incarcerated mothers who want to provide milk to their babies. And COBA has some grant funding to help get that program launched. And then our Mother's Milk Bank staff will be collaborating as well to get the milk safely delivered to wherever the baby is around the state. So we're very, very excited about that. Next slide, please. And yes, and just our last one, just a reminder, COBA has 2 rounds of scholarship applications, and they accept applicants for scholarship funding that are either applying to take the IBCLC exam, which is given twice a year, or trying to acquire some of the lactation education that's needed to qualify for the exam. So that's the next 2 upcoming deadlines. And the focus for the COBA Scholarship Program, of course, is to increase diversity in the lactation field so that we can have more representation from our BIPOC community in the IBCLC profession. So just a reminder of those scholarship opportunities out there. And I think that's my last slide, so I'm happy to answer any questions.
Hey, exciting news, Becky.
Yes, yes.
Very good. Any questions or comments for Becky?
Everybody's ready to go for morning coffee break.
Well, thanks again for
there's no questions in the chat, but there is a lot of helpful links and a link to the scholarship opportunity if you have questions for that.
Great.
Very good. And we'll get these slides out later too, so additionally people can access items directly from the slide. So thank you very much for sharing this wonderful information. As you can see, we have many good things going on to reduce infant mortality. The reason, the major contributors, I feel like, to us being able to lower that rate. And so keep the good work going, everyone. It takes a joint effort, and we appreciate everything that's being done. We do have some health awareness acknowledgements just coming up, just to let you know about. World AIDS Day is December 1st, and also Safe Toys and Gifts Awareness. We'll be putting out more information in relation to this. Is also a December awareness. So we want our kids to get great things for Christmas, but we also want them to be safe and enjoy them safely. And then also in January, coming up before our next meeting, is National Birth Defects Prevention Month. And we know that's very important to prevent congenital anomalies and infant mortality related to that, and Cervical Health Awareness Month. Also, just want to say again, remember this is Prematurity Awareness Month. So let's get our messages out and do everything we can and take advantage of this month's focus. Also, the World Prematurity Day is November 17th. Many activities going on throughout the state and nation. So please take advantage of those. Also, we will be posting many social media. We'll have digital ads going out, PSAs, and information in relation to best practices, and also messaging to keep your baby healthy and hopefully from being premature. So we also have a summit coming up. Denise, would you like to give us more information in that regard?
Yes, thanks, Joyce. Just wanted to remind everybody that on the 18th of November, so a week from tomorrow, we are having our annual Oklahoma Perinatal Quality Improvement Collaborative Summit. We are going to be meeting in person this year, so we're very excited to see everyone there. We will be sending out our finalized agenda later today, but if you have not yet registered, I did drop the link for our registration in the chat. So that's opqic.org/summit22. We will be at the Moore Norman Technology Center South Penn campus on the south side of Oklahoma City. So hoping to see you all there. And I know that there was a lot of great information brought to us from the work groups today. So we do have some slides that we do run between our sessions at the summit where we try to provide some of this information to our attendees. So if you all have any information, just slides that you can send to me, we'll make sure that we can get that information out to the attendees at our summit. So I will drop my email again in the chat for you to send any information that you might want us to present.
Perfect. Thank you, Denise, for that opportunity. Anybody else have announcements that they would like to make in relation to upcoming events? Okay. All right. Well, again, thank you very much for joining us today. And we will hope to see you next time. Also, in addition to Prematurity Day, it is Veterans Day tomorrow. So please recognize our veterans, thank them for their service. And we will see you next time. Thank you, everyone.